This sitting is resumed. We revert to Standing Finance Committee.
This House is in Standing Finance Committee. Honourable Prime Minister.
Thank you very much, Mr. Chairman. First of all, let me start off by thanking the members of this ministry who, I would have had a unique opportunity to work with between 2020 and the end of last year as we managed perhaps the most difficult period of this country's post-independence existence over a 3-year period. It was not easy, and it placed unbelievable pressure on all of you in your different capacities. I want to formally yet again, and it will never be too much, to register my own personal appreciation, but also the appreciation of this government for the work that you were able to do in conjunction with your partners in the private sector and in the broader civil society to be able to help bring this country safely over the course of that period. I've indicated on many occasions, as recent as Saturday, when I was touring AgriFest and the press asked me some questions, that when we came to office, it was our judgment that healthcare and agriculture were the stepchildren of post-independence Barbados development. In other words, they were there. We admitted publicly to loving them, but we didn't have the level of support and care and nurturing necessary for them to flourish. And that this government committed that it would do all within its power, in spite of being in an IMF program, to remedy this situation. Because with an aging and declining population, it becomes even more important for us to ensure that those in whom we have invested much as a nation can live the longest and best life possible. We've been lucky in that we do have generations before us that have lived long, and that Barbados has one of the highest per capita incidence of elderly population in the world, centenarians in particular, and akin to countries like Japan that have really excelled in this area. It is in no small way due to, one, an excellent public health legacy, two, a strong commitment to primary health care, and that is at both the nursing level and the level of doctors. Three, a strong sense of personal responsibility, much of which may have been imposed on previous generations because of their lifestyle, in terms of their diet, and in terms of their level of activity. I would like to believe that the investments that we continue to make in our people will go the longest possible distance. And the longest possible distance, therefore, requires, one, and the executive chairman would have spoken to the 4 or 5 things that she believes from a hospital perspective. But the Honourable Member for St. Philip North has been given specific responsibility for allowing us to fight the battle against chronic non-communicable diseases. And it is deliberate because we accept that a key part of that is individual responsibility. I'd like to hear some more, and some of it you may have said already because I've been in and out of the House, as to what is being done in this respect. I'm going to come back and I want to hear on the government's program for antimicrobial resistance as well. I'm just giving people time to prepare themselves for where I'm going. Because as you know, I cannot co-chair the One Health Global Initiative, have the meetings that we had as recent as 3 weeks ago in Barbados, after 3 years of virtual meetings, have as many people that I know personally die from AMR, and not be true to the position and office that I've accepted on behalf of the WHO, UNEP, OIE, and FAO with this respect, to ensure that Barbados can run its course fully in minimizing the incidence of death in this area. Thirdly, I'd like to hear the minister specifically speak to the question of ensuring access to the most modern treatments for oncology. He spoke about the genetic markers and the genetic sequencing just now, but he has responsibility for building out the pharmaceutical industry beyond where it is. Barbados has a proud history with Collins Limited, I think, operating, over 100 years? And the question is, we are seeking to carry it to the next level, but not just to earn foreign exchange and to get jobs, but to improve access for our people in the Caribbean and Central and Latin America with respect to the most modern oncological treatment, whether through mRNA technology or monoclonal antibodies or whatever else is put there. And finally, I'd like to hear the executive chairman of the hospital make the case for the capital program in 12 to 18 months rather than the 5-year horizon that she has put on the table. Because once the government settles the funding off balance sheet, then there is no reason why you should be waiting 3 to 5 years to execute. And secondly, you can't really be telling me about a shortage of skills in this country to constrain the functioning of the QEH, when the QEH has had a distinguished history of bringing in on short to medium-term contracts the skills necessary which are not immediately available in a small island. Recognizing that it is our intention to offer opportunities with free tertiary education, as we do, to every possible Barbadian. But even if we did it for everyone, there will still be some areas in a population base of under 300,000 that will remain lacking, and therefore think, and the minister will know them better than any of us perhaps in here, of the numbers of people who have served at the QEH in short-term contractual arrangements that are no longer in Barbados or have moved on in Barbados to private practice, but are not originally from Barbados or having been trained in the Caribbean. So I've laid out a number of questions, and I hope that that will carry us safely over the next few minutes. Thank you.
Thank you, Prime Minister. I ask Minister Brown to lead off with the NCDs.
Thank you, Minister. All right, as I understand it, the Honourable Prime Minister wants to know what is happening with the NCDs since my being here, correct? Okay, let me begin.
I think I know, but I think through me, the public wants to know.
That's all right.
Thank you.
Let me begin by saying that over the last year or so, since being in office, we've been paying special attention to the NCDs, and you would have noticed several public engagements. We have all heard the statistics that some 80% of the NCD patients are dying because of the situation, and we recognize the urgency with which we need to tackle the problem of NCDs, first by tackling, well, not first, in tandem with tackling risk factors for prevention of NCDs, and then dealing with the present cases of NCDs to lower the public health burden, as well as the economic burden on the island. Since I've been here, earlier Dr. Phillips spoke a lot on the NCDs and what we're doing, but since I've been here, we've been going in a public health perspective. We had discussions, and we are still working in tandem with agencies like CARFA and PAHO, WHO, the NGOs, Healthy Caribbean Coalition, Heart and Stroke Foundation, all with the same goal of bringing awareness to the NCDs, tackling the risk factors with an effective decrease in the burden. Over the COVID pandemic, we all realized that the focus would have been on COVID, or was on COVID mostly, and NCDs took a middle or back burner position. It is now, in my mind, to the front of the burner again. So we saw an increase of cases of NCDs, especially appearing at the hospital, because services were basically, as I said, put on the back burner in the primary care setting, where the patients were scared to go to the primary care physicians, including the polyclinic. But some of them were rationing tablets, I know that personally. Some of them were stretching their appointment time. So the things like diabetes and hypertension and cancers got out of whack. We saw maybe stage 4 cancers increasing in terms of presentation. I had a few at that time, increasing in presentation because of the delay in seeking treatment. We recognize, and I hope I'm not wrong, we recognize that physical activity and diet play a major part, apart from tobacco use, alcohol overuse, and diet in terms of NCDs, and hence we assisted the Ministry of Education in rolling out the school nutrition policy, which was launched not so long ago this month. So that meant guidance to the Ministry of Education in working with the curriculum of the school, working with the school meals program in terms of the offerings of food, and making them not only palatable, but falling in line with the levels that we want to see with sugar and salt content. Those numbers are still to be ascertained before we can go even higher in the fight with salt and sugar. We met through partnership with PAHO, we met with some of the stakeholders, and the buy-in was really good in that conference in October, was it? In October, and that was a forum where we discussed possible reformulations, what the private sector, including the fast food agencies, were willing to do. We were to meet on that again, but things got in the way, like estimates and so on, so we were meeting on that fairly quickly. I think one was supposed to happen to Friday, and it was delayed. So that was enrolled, so we were to sit and decide, one, on the levels of salt that are acceptable, as well as sugar. You would know, Prime Minister, through the chair, that the increased tax on the sugar-sweetened beverages was added. The focus now will be to see how it has impacted in terms of the quantity being used by the public. So that is one thing. The minister and I, substantive minister and I, were involved in the recent discussions with the small island developing states on NCDs, including mental health. It was a very healthy discussion, and this will go forward to go to the ministerial conference in June, and then again in the high-level meeting in 2025. So the whole focus, not only with Barbados and the region, but the rest of the world, is to put, especially with the small island developing states, which probably are more impacted than the larger countries who can stand on their own, will be to put forward suggestions and protocols, etc., to tackle the NCD problem with the few resources as compared to the bigger countries that we have. What else in NCDs? Well, we realize that the hospital, as I said before, is inundated with the burden of NCDs. because of the escalating, the morbidity was increased, associated morbidity with respect to the NCDs. The hope now is to increase the capacity for the primary care setting, i.e. the polyclinics, all 9 polyclinics, so that we can get back on board and to ensure that the risk factors are addressed, people are educated, from the smallest to the oldest. So the plan now is to involve these schools even more. But leading from the school nutrition policy that was just launched, the plan is to go forward to do a national policy that involves non-school entities. So in terms of putting things like diet ahead, I know the hospital, the kitchen area, the food supply there have been many complaints, and people were basically saying that during COVID, the outsourced entity was providing tastier foods, but what a lot of people did not know that our onboard dietitians in the Queen Elizabeth Hospital actually provided the recipes for that process. So that tells me that it can be done within the QEH unless the higher plan is to outsource the provision of diets and food within the hospital. What else has been going on? I'm thinking.
I think that has given us a good summary.
Okay.
Suffice it to say that I do think your last point with respect to ensuring that the quality of meals, and I think that the executive director of the QEH knows how I feel about that the quality of meals has to be first and foremost appropriate to the health profile of the patient, and then second, tasty. And because if it tastes bad, people ain't gonna eat it, however much they need it, and we all know that. So I think those 2 things, we want to make sure that we are fully on top of that, because there's no excuse for us not to be. And I look forward to hearing you on that separately. I see that Dr. George wants to speak.
Thank you, Most Honorable House Kenneth George, CMO. So there are some additional things I will mention. We have a strategic plan, 5-year strategic plan, that has been costed and is coming to Cabinet shortly for, and once they accept, we will get cracking. We have taken the approach that we need to standardize the care for our common NCDs like diabetes and hypertension. So we have adopted the HEARTS program, which is a standardized form of care that ensures that the outcomes are better than if individuals choose their own methods of care. And the polyclinics are engaged. The commission recently met. The commission has not met for a very long time, which is sad. But they started back in earnest, I think 1 week ago, and they are willing to hit the ground running.
I'm not sure that 1 week ago is in earnest, but they've started.
So let me say that we are coming out of COVID, and we realize that the Mental Health Commission and the NCD Commission are important moving forward with respect to our programs. Finally, you heard if Barbados becomes trans fat free by December 2024, that will be an outstanding and transformational type event. We have always said we need data to make good policy decisions. So we are trying to work for a low-cost online NCD survey very soon, using some funding that we have identified as savings.
Will this also include a Caribbean calorie counter? Because I think that there is a partnership potentially with the commercial sector. When they came to complain to me about the excess fees that we put in the last budget for sugar, I put on the table that rather than complaining and asking me to ease back, could they please finance a Caribbean calorie counter? Most people are unaware that a roti this size probably has close to 1,000 calories in it. And if they knew that, even if they wanted to taste the curry or the flour, they would eat half of it instead of the whole thing. So that this level of public education and the calorie counter, the NHS in England can't have a calorie counter for cuckoo, and Barbados don't got one. So I really, really want to urge the ministry, and we will work with you to make sure that by next year, this time, just as we worked with you on the cardiac project, that the executive director has shown that we now have the 24-hour support services, we will work with you on it. Because if the minister, the honorable member for St. Philip North, is to be successful, then the first thing people need to know is what it is they're eating and what the impact of it is on them. And as you talk about trans fats, I'm not a doctor. Break it down, sir. Break it down for ordinary people. What is this trans fats that you're talking about? Because my constituents need to know what they should go for and what they should avoid. And if the trans fats are found in things that they are buying now, then if they want to look like the honorable member for St. Michael South or the honorable member for St. Michael South Central, both of whom like to be fitness aficionados, then they need to know what to stay away from.
A trans fat is a hydrogenated trans fatty acid.
I think that this is the first occasion, Mr. Chairman, through you, this is the first occasion in 30 years in this institution that someone has, in fact 32 years, that someone has sought to explain things in a simple format by making it more complicated.
No, I will try to be real simple. So we have fatty acids which are critical in our body. And if you add a hydrogen onto it, it has the there's no other way to say hydrogen, people. Right. And that adds, that causes the arteries to be hardened, to be thickened. It's all about arterial buildup of plaque. So we...
Break it down. And when that happens, when your arteries get clogged, that's the word you want?
You get heart attack and stroke.
Thank you. And the level of heart attacks and strokes that we're seeing in the country
is way too high.
Directly attributable to this type of eating.
Right.
In other words, eating a lot of foods that fried with what?
Oils.
What kind of oil? Because there are good oils and bad oils.
So Bajans just talk about lard oil. The oil that gets
That's
hard.
why I want you to talk, because they're only talking to us in here, you know.
The
They're
oil
talking
that
to everybody
gets-
who listening at 5:30 in the evening.
Right.
Hello.
If you cook a meal that, if it gets, not even putting it in the fridge, you see like lamb, you get a thick crust over.
In other words, the oil is clam up fast.
Right.
Right.
That
Or clog
is,
up fast.
that is a possible indicator that
That you shouldn't use that oil.
Right.
And that basically you want to avoid it, because if it can clog up fast out there in the atmosphere, imagine what it can do inside of your body.
Right.
That's what you're saying?
Yes, that's a
Lord
good
bless you. Thank you. The other responses, that, and we've made the point, and that's why we want to support you, Dr. George, that the country is facing a diabetes epidemic in real terms. And we may be laughing and talking and thinking here, but diabetes, strokes, heart attacks, we assume that people know what we mean when we say chronic NCDs. I've learned the hard way that a lot of people don't. And therefore, I want us to break down the language, because if we are to be successful, we need to bring people on board. And as Bajans say, one blow is kill all cow. So if we have to reduce the language where people understand what we're talking about, you understand? Then we need to do so, even if it means talking about a Passover and different other things. All right?
Understood.
Please.
PM, I wouldn't want it to go out there that the only risk factor is trans fat, because there are others out there.
No,
and
that's
I
not
said,
the only one.
And I said earlier that 80% of Barbadians are exposed to them. Tobacco, alcohol
That's
abuse.
why stop smoking.
Alcohol abuse, lack of physical exercise, and poor.
Agreed.
poor
And that's
eating
why stop
habits.
smoking, start exercising.
And of course, genetic.
And I hope that people will only use alcohol in modest amounts as well. But all of these things do count, yes.
I'll ask Dr. Best to speak. He's the lead person on AMR in the ministry to give where we are and our plans for the next year.
And when he's finished, I'd like to hear from Dr. Ford as well, who has been helping me internationally.
Ford, Andrew.
Thank you, Minister. Thank you, Chair, for the opportunity to say a few words on antimicrobial resistance, which the Prime Minister has asked us to talk about, given her role on the global stage where antimicrobial resistance is
Dr.
concerned.
Best, we know who you are, but
Sorry.
you need to register your...
My sincere apologies. Anton Best, Deputy Chief Medical Officer. So antimicrobial resistance, in a nutshell, we have microbes which cause problems in human health and in animal health, whether it's bacteria, fungi, parasites. The problem that we are facing now is that there's an increasing rate of resistance to antimicrobial agents. So the agents that we customarily treat these microbes with is becoming, not necessarily becoming stronger, but the microbes are becoming more resistant. And part of the problem from a pharmacological perspective is that we're not investing in the level of research and development to come up with new agents to be able to treat microbes. So Barbados has long had a program in antimicrobial resistance. However, given the recent increases and attention at the global stage, there's more attention being paid nationally to antimicrobial resistance. So we have an action plan. The first iteration of the action plan that I remember was in 2017, but in recent years, the action plan has been revised. And in fact, we are updating the action plan and implementing key elements of the action plan. And I'm going to touch on some of those key elements. In terms of governance, we now have within the Prime Minister's office a Global Leaders Coordinator, Liaison Officer. So basically the hub of the national response to antimicrobials has been moved out of the Ministry of Health and within the Office of the Prime Minister, but of course working in collaboration with us in the Ministry of Health and Wellness and the QEH. In terms of health promotion, we need to sensitize the public of Barbados what antimicrobial resistance is about and what their roles and responsibilities are in terms of addressing this potentially next pandemic of an issue. We also have to resensitize our healthcare providers, and I'm talking about nurses, doctors, I'm talking about pharmacists, about antimicrobial resistance and of course their roles. It also makes us look at the protocols for how antimicrobials are to be dispensed. So one thing that we should not be doing is going to the pharmacist, for instance, and saying, I have a cold, can I get some penicillins, can I get some antibiotics? First of all, a cold, if it truly is a cold, is a viral infection, and antimicrobials, or antibiotics rather, are not indicated in that setting. So that's the responsibility of
I would like you through, Mr. Chairman, for Dr. Best to repeat it, because this is perhaps one of the biggest problems among ordinary households in this country. People feeling that, oh, I got a cold that lasting too long. I could get antibiotic, please? Please.
Absolutely. So the problem is twofold. So the problem starts arguably with the patient who demands it from a pharmacist. Now, notice I have not said anything about a doctor. So the existing law is that you can only get, or you should only get an antimicrobial once it is prescribed by a registered medical practitioner. But we all know that one of the practices happening in Barbados, and it's not isolated to Barbados, is that persons can go to a pharmacist and say, I want an antibiotic for this particular problem, and the antibiotic is given. So that's a no-no. So we don't want the demand for it coming from persons in the community. We also need to remind pharmacists of their duty that they should not be dispensing antibiotics in the absence of having a prescription from a registered medical practitioner. So we also have to resensitize the pharmacists, as I just mentioned. We also have to sensitize and educate doctors about the safe use of antimicrobials, when they're to be used, etc. In the hospital, we have something called the Antimicrobial Stewardship Program. Within the National Action Plan on AMR, we have articulated the need to expand beyond just the borders or the walls of the hospital and have an AMR stewardship program at the district hospitals as well as in clinics in the private sector as well as the public sector. There are other aspects of health promotion that the action plan speaks to, such as the infection prevention and control basic strategies, such as hand washing, for instance. Once again, we always talk about hand washing to reduce the spread of germs. We focused a lot over the last 3 years on the importance of hand hygiene to reduce the likelihood of COVID. It also has a benefit for the reduction of spread of other microbial diseases out there. And of course, if we can reduce it that way, we then have a lower dependence on the use of antibiotics. So those are some of the key strategies that we are implementing. I just want to end off on talking about two things. One, about surveillance. Surveillance is in a nutshell, the acquisition of information on the burden of antimicrobial resistance out there, and it starts in the lab. So we've strengthened not only the lab at the Queen Elizabeth Hospital, but also the Best of Santos Public Health Lab. But those are the medical or the health laboratories. The labs in the Ministry of Agriculture, for instance, and the private sector labs also have a key role in addressing surveillance needs for antimicrobial resistance. We've also looked at the equipment needs that are required. So in the estimates for the upcoming financial year under the Best of Santos Public Health Laboratory, we've identified the additional equipment that is required to do the surveillance that is necessary for antimicrobials. One key point to make is that we have a One Health approach when we talk about antimicrobial resistance. It is not just human health that we have to have in mind. We have to have animal health as well as environmental health, because you will be able to detect antimicrobials in different environments, and also what happens outside of the human health arena also has an impact on what happens to us in the community. So that's why we have to have the heavy engagement of the Ministry of Agriculture, for instance, in this AMR effort. On a final note, I just want to mention some collaborations. Just yesterday, the Ministry of Health would have met with the ambassador from Argentina. And just before COVID, through the Argentinian government and in collaboration with the Pan American Health Organization, a program to strengthen antimicrobial resistance testing in the Best of Santos lab was started in collaboration with the government of Argentina. So in meeting with the ambassador, we did express our gratitude for this collaborative effort and hope that it can continue for the foreseeable future, an excellent example of South-to-South collaboration. We continue to work with the Pan American Health Organization as well as the World Health Organization to build capacity to be able to address AMR not only locally but regionally. And we also are looking forward to working with the Caribbean Public Health Agency based in Trinidad to address the AMR. So with those 3 words, thank you very much.
Thank you. I don't know whether Dr. Ford wants to add anything to that, given the work that we've been doing, and then the CMO.
Thank you. Good afternoon, Honourable Prime Minister and other honourable members sitting here today. I am Dr. Corey Ford. I am an infectious disease doctor, but also the clinical director for clinical and diagnostic services. I just want to add a few key things, especially to all in here and to all who are listening on today, which I think is strategically important. The World Health Organization, as it is, has really defined, and to get your idea and the concept of what Dr. Best was speaking about, it's really defined by 2050. We talk a lot about NCDs, but by 2050, the most common cause of death globally is expected to be as a result of antimicrobial resistance of sepsis and infections. I'm sure everyone in the room knows somebody who's had an infection. But even at this particular point, there is a death every 6 minutes or so from some sort of infections referred to as sepsis in general. I think there is a big connection between NCDs and antimicrobial resistance, and I think that needs to be mentioned in this room today. Persons who are diabetic, hypertensive, even who have cancers, are a little bit more susceptible to death from antimicrobial resistance, and I think that's important to mention. The QEH in itself, in 2016, has started an antimicrobial stewardship program. And within that antimicrobial stewardship program, that is a group of persons, infectious diseases, an infection control team, and we're able to gain one person during COVID, we were able to train another person with infection control. He was an orderly, but now he's an infection control individual. In that group as well, we've also coordinated to work with the Best of Santos laboratory, so they also join our rounds as well, and it involves the physicians, predominantly the ICUs, in this particular program. This program is targeted at efficient and appropriate use of antibiotics in individuals. What I will inform you today, and I was only talking about this during the lunch period, I think is important, is that only within the last year or so, I'm going to say post-COVID, hopefully, what we've actually seen is a rise and increase in the amount of cases, for example, of presented to the hospital from the community, and this is very important, with organisms causing infections for which we have a minimum amount of therapies for in Barbados. This is a strategic point and really has led the team to decide that we need to do a bit more within our communities and move this whole idea of stewardship just from the acute hospital care setting to move it into the long care setting. We expect to really work with the geriatric hospital in our first phase. But in the second phase of what we plan to do in terms of improving antimicrobial resistance through this stewardship program is to move this to the community, to the average Barbadian on the ground. I think the education of people in the use of antibiotics is important. Antibiotics are not for everything, but also education of pharmacists, education of doctors as well. I think that's also strategically important. So I think those are all the phases we're going to. So I think as a hospital in an acute care setting, it's important, but I think we also need to move this whole idea of preventing infections in the community. And then the last leg of this, before I complete what I'm saying, is the infection prevention control. So there's a point where you can use antibiotics to treat infections, we also need to stop the spread of infections. This is where the infection control team comes in. You'll see in the request a need for infection prevention control, but a very important part is a need for antimicrobial stewardship / infectious disease pharmacists. This becomes strategically important, not only within the hospital setting, but fighting that fight against antimicrobial resistance. And ultimately, everything really comes down to leadership, and I think we have that leadership coming directly from the Prime Minister's office, which is unique for many countries. Thank you.
Thank you very much, and I'd like to thank all of you for supporting us, not just locally, but internationally in this effort. I think Dr. George wanted to
I'll be real quick. We are very fortunate in Barbados. Many people may know that millions of people die a year from malaria, tuberculosis, and HIV. And one of the key drivers of that is the resistant strain throughout. On the brighter side, we got information that there was a pandemic fund, a pot of money floating around which Barbados could have tapped into. I hope that this can be used for our antimicrobial resistance program. In addition, it can dovetail into adding technical assistance for accreditation of the Best of Santos Public Health Laboratory.
Thank you for that reminder through you, Mr. Chairman, and to simply say that in the same way that we've managed to raise significant grant money for the Barbados Water Authority, I don't think this country has ever gotten $80 million in grant from anybody since independence. I look forward to the Ministry of Health putting together the paperwork, UNDPS, and the minister, and my working with you to make sure that we can leverage access to this fund. You've gotten it already? How much?
No, we did the expression of interest.
Well, the expressions of interest. This is the one that Dr. St. John sits on as well. The head of CARF, I should say. Yeah, I'm aware of it. So I look forward to our being able to continue to benefit from these grant funds wherever they can. We have already placed enough in the international community for us now to start getting something back. The next question, the minister was asked about his role with respect to the pharmaceutical industry and making oncology medication and therapeutics more available, the more modern ones, I'm told. I think Mrs. Hines had indicated to me that we don't have access to all of the modern therapeutics necessarily. And to the extent that we can develop a pharmaceutical industry, it's not just Barbados, by the way, I should say the Caribbean and Central and Latin America as well. So that is why the government is driven to ask you to lead the effort on the pharmaceutical industry, and maybe you just want to speak about it briefly. Thank you.
I may say it came essentially, as I think most honorable members are aware, out of the visit initially of President Kagame to Barbados in April 2021, I believe he was here. And during discussions, we heard of this new venture which was about to be launched in Rwanda, using the mRNA technique that had been developed, and out of that had come the AstraZeneca vaccine.
I think it's April 2022. That's how much work you've done in less than a year. You're shortchanging yourself.
Perhaps. Perhaps. Anyhow, we got interested in this, and he invited us to the launch of the project. This was in June 2022, I think it was. Unfortunately, you weren't able to attend. But however, we've had discussions. We have a group here, Dr. Bess, Dr. Miriam Hines, and others have been involved in the process. Prime Minister, you and President Ali of Guyana and President of Rwanda, Kagame, met on the side and margins of COP27 in November last year to discuss further in the whole issue of pharmaceutical equity for global public health. And present, I don't know if it was coincidental or incidental, was the European Commission head, Ursula von Leyen, also President of the Investment Bank, European Investment Bank, Dr. Werner Hoyer, and of course, Director General of the World Health Organization. And the key recommendations coming out of that meeting were obviously that there was need for intergovernmental South-South cooperation, an initiative aiming at the development and manufacturing by 2040 of 60% of essential pharmaceuticals for the populations of Latin America, the Caribbean, and Africa. And this was we call it transatlantic bridge. And it was intended that the focus of cooperation would be on the next generation of oncological drugs, recognizing that with the whole issue of genetic sequencing and the mRNA techniques, you can use these for oncology and treatment of cancers. And also looking at preventative and therapeutic vaccines, as well as specifically for Barbados, an interest in modalities for women's health. This process is moving on, and I believe that we are seeking to establish pharmaceutical manufacturing in Barbados, and it will require significant work. I should mention that Dr. Bess, Dr. Hines, another person, visited Rwanda in December last year to Dolores to look at the entire project as it comes to dealing with the regulatory framework and the sort of things that we will have to do in Barbados. It is the government's intention to proceed on that. Of course, there are certain requirements. It needs, obviously, you'll have incorporation, the selection of the recommended possible locations for pharmaceutical manufacturing, the hiring of consultants is required, preparation of briefs, etc., sourcing of potential investors, and Prime Minister, perhaps you would know that there's going to be a visit potentially in 2 weeks, I think it is, potential investor in this project to Barbados. So Barbados, in joint collaboration with the government of Rwanda, is hoping to piggyback on their technical knowledge and expertise to see if we can establish this pharmaceutical manufacturing entity and process in Barbados. We'll have to look for location, obviously finance, the issues of water, supply, transfer of knowledge, and of course, energy. And the emphasis on this entire project, it must be 100% clean energy. So that this is a substantial work that we as a government are undertaking at this point in time. Hopefully emanating from it would be some new and wonderful drugs, pharmaceuticals coming out of Barbados. That's it in a nutshell.
And then I think I asked the executive director some questions that I hope that she will ball back a York at me so that I can take it for 6 to the boundary.
Thank you. Thank you very much. Prime Minister, you had asked us how can we essentially fast track what we articulated as a 5-year plan to a much more truncated time frame.
Only because it does not depend
Yes.
on government's cash flow.
Definitely
If it is
so.
off balance sheet. And I'm aware that the minister in the Ministry of Finance has been facilitating discussions between you and members of the local financial community, I think
Yes.
the credit unions in particular, to be able to take care of that. And secondly, to have a person who is the Minister of Housing vest the property that the QEH is on, which ironically has never been vested in the Queen Elizabeth Hospital and still is state lands and hence is not on your balance sheet. But continue, ma'am.
Prime Minister, you stole my thunder a little bit.
No, because that's not your thunder. That's the context in which you're
Right,
operating.
so that
I
is-
need to know from you
Yes.
whether the $135 million in equipment
Yes.
is equipment that you need now in the next 18 months or not.
No, definitely.
If you don't, then I understand the phased approach. Because if you're saying that you're replacing equipment that still has 3 years life in it or 4 years life in it, I understand the phased approach. But what I want this honorable chamber to understand is that so long as we can move it off balance sheet, there is no reasonable reason to be able for us to put it off. And I believe that the minister has been very strong on wanting to have the complete capital arrangements. I am equally strong on wanting to see all 12 surgical theaters operating, even if we make 3 or 4 of those theaters immediately available to the private sector, because Barbados's health services is not only governmental, but it is always best when it is government plus private sector. And to the extent that we can give them access to assets that are sitting now idle, we increase the opportunities for people to benefit. But continue, ma'am, please. Because
Yes,
you have
Prime-
to find details that
Yes.
we don't have.
Yes, Prime Minister. The reason why we are of the clear appreciation that we should go for a more holistic approach to bringing in the CapEx funding in a larger tranche as opposed to phasing it over 5 years is because we recognize that the practice of medicine and how we work in the hospitals, that the things are interrelated. So for instance, if we, as we're currently doing, strengthen our cardiology department without at the same time strengthening our radiology department with an advanced CT technology, then the cardiologists are still going to be functioning with one hand tied behind their back. So we had phased it only in our initial planning to just make it manageable, but with the investment that has been made in creating the opportunities to leverage finance through the Ministry of Finance of what you're doing with the land, and with the fact that we would have had debt removed from our books within months of coming into office, it means that we have been preparing, or the Ministry of Finance have been holding our hands throughout these past few years to get us exactly in this position. So when you look at our CapEx plan, there is a direct relationship between the needs and requests that are coming in the different disciplines and the areas in which they're cross-cutting clinical and diagnostic services. So we believe that we are in a position, we know what are our immediate priorities, CT scanner and other initiatives, and we are in a position, if we're able to get the funding to really move much more faster in making the hospital fit for purpose in terms of equipment. So yes, because we're aware of what we need and we know the relationship between the pieces of equipment, we're ready, Madam Prime Minister.
And on this last one, Minister, the government of Barbados does not have $1 billion to build a new hospital. But the combined capital works expansion that you are doing, do you believe that the Queen Elizabeth Hospital, with those combined expansion works, the upgrading of polyclinics like Randall Phillips and Winston Scott and Morris Bayer, can deliver for the country its needs in the next 15 to 20 years, combined with the private medical hospital proposals, of which there are now 4, I believe, 3 for sure, and a 4th one came on the table 2 weeks ago for me to meet with them in 2 weeks' time, which is based on medical tourism plus domestic usage, as opposed to just medical tourism alone. Perhaps this is an opportunity for you to use your considerable experience, not just as Minister of Health, but someone who set up the Caribbean Public Health Agency, someone who has been a distinguished fellow surgeon. Give us your honest opinion as a Barbadian, and for the record, as a Barbadian who knows what it is to have grown up and worked their way up the pan, and to know that I know your heart, and I see it every day, is in helping people who would not otherwise be able to be helped.
PM, you're asking me to answer that question now?
You are returning to me what I told the Swedish reporter. Yes, I am.
Well, with all the capital investment going around the QEH and within, and I'm going to be a little greedy, I don't know that you can just refurbish 3 or develop 2 or 3 polyclinics. I think it has to be a global thing. This is where we were 15 years ago, perhaps, that we need to upgrade our polyclinics and the hospital at the same time. We reduce the burden on the QEH. We allow it to get on with this business. So it can be done in 10, 15 years once we have the resources and once there is that spirit and conviction that it can be done.
And you accept that where there's a deficit in skills, that we import skills while building skills among Barbadians. Yes?
We have to.
Thank you.
And it allows us to train more people need more resources, nurses, etc. here. Yeah.
Well, I will end by telling you that while I have no children, I have adopted children, not stepchildren. And health and agriculture have become my children since 2018. Thank you.
Thank you, Prime Minister.
Thank you, Honourable Prime Minister. Honourable Member for Christchurch West.
Thank you very much, Mr. Chairman. And I do recognize the hour is late, and I will truncate my 3 questions to 2. I won't speak about the dental problems that you're having. I think that those have been answered pretty well. Suffice to say that it is clear that you need people with dental experience, and you need even more people with oral surgical experience. Enough said on that. But clearly, clearly, no, it's not a question. I've said it from kin to 2.
No, I heard that you were interested in professional dentists.
I will leave that by, let that go by. I wanted to drill down because you, Minister, there was some mention of HPV vaccination and its role in preventing cancers. You know, I talk about this all the time. And I wanted to get some more information as to what actually is your penetration of the vaccination. How many people are you getting to vaccinate on an annual basis, boys and girls? And if you're not getting the numbers that you want to get, are you doing any public service announcements and other means of getting more people to buy in on getting the HPV vaccination. Clearly, it is demonstrated that this is a preventable cancer, a preventable way of preventing cervical cancer. And I think more and more of our people need to understand that this is an opportunity for them to prevent a cancer that is, I think, third or fourth most prevalent in Barbados. So that is my first question. What is your penetration? And if it is not the maximum, what are you doing to get to the maximum?
Thank you, Minister. You would be aware that in the last couple of months ago, Cabinet did approve a paper that spoke to, focusing on the HPV distribution and a one dose, and also focusing on boys. You mentioned cancer of the cervix, but it's also cancer of the cervix, and also things that occur in your throat as a result of HPV. I'll ask Dr. Ingrid Cumberbatch to speak to that because she follows these matters.
Thank you, Minister. Ingrid Cumberbatch, Senior Medical Officer. Thank you very much for that question, Minister, because it gives me an opportunity that I've been looking forward to. And the HPV vaccine, as Minister would have said, we were able to get a policy change where that vaccine is now a one-dose vaccine from November 2022. We got that approval for that policy change. And that policy change was based on the recommendations of SAGE WHO body, who we follow in terms of best practices for immunizations. To answer your question about our penetration or our coverage for HPV, I'm going to speak about the HPV one dose. The coverage for 2022 was 47%, and this includes both boys and girls. And our cohort that we target is 11 plus cohort, as you would be aware. This compared to 37% in 2021 and 63% in 2020 and 67% in 2019. So what are we planning on doing in order to improve the coverage? Well, one of the first things that is important is letting persons know that the HPV vaccine is now a one dose, because that was one of the main challenges that we were having where we had a 2-dose and expected persons to come back. It was certainly a challenge for the person who had to come and get the vaccine in terms of the parent and the child, and also a challenge for the healthcare worker. So with the vaccine being a one dose now, we intend through Vaccine Week of the Americas, that is coming up at the end of April, the 22nd to the 29th of April, to send out PSAs reinforcing what I just would have said to the public and encouraging them to have their children to be vaccinated, both the boys and girls. In addition, the other plan is that when it comes to the 11 plus exam, just a week or so after that, because that is when we start giving our 11 plus boosters, that we reinforce that public service announcements again. And of course, through our polyclinics and our pediatricians and the other members of our fraternity who are part of what we call the expanded program of immunization, they also are telling the clients that we are having the HPV vaccine as a one dose. So those are some of the initiatives that we're looking at doing at this point in time.
Of course, you would agree that that coverage is not the amount that you want at all.
Certainly not.
And you definitely have to improve that coverage substantially. So I look forward to hearing the public service announcements, and to then maybe I'll be here when you come back in the well another time, and I'll be asking you a similar question, and hopefully you'll be telling me the coverage is 85, 90% and not 47%. Oh.
But I should just caution, it used to be 12 and 13 at one sense. I agree with you, it is not where it should be, but we are getting there.
And my second question has to do with the cardiac care project. And I applaud first the success that you've had. You would recall that it was mentioned in the well, and that cardiac care project was first discussed right here. And my question has to do with, now that you have it going, what results have you been able to achieve from the program? In other words, have you achieved better survival rates than we had before? Is it measurable? Have you started to measure those survival rates? And then secondly, what improvements in terms of the care of the training and the equipment has been made available for the paramedics? because at the end of the day, they are the first responders. I heard you with respect to what is happening in the hospital, but what training and what additional equipment has been made available for the paramedics as the first responder? And then, of course, what measurable results do you have? What actual measurable results from the program do you have?
Thank you. First of all, there are no measurable effects right now. You recall it has 4 phases. The first phase, that will be public education, the agreements with the private sector providers so that they could administer the fibrinolytics. You also had a phase that dealt with the ambulance, the paramedics. I believe they went ahead of the whole process because they were trained, and now they need to be retrained because we've been talking about this for 2 years. Then we finally finished the MOUs with the private sector providers. I believe there's one emergency service that provided that opted out. And now we're moving ahead, getting the necessary equipment and the staffing. But what the QH has done to push the process forward, have already identified a location, a space, the chest pain unit, have had meetings with the cardiologists to push the process forward. But I'll let Mr. Harris speak to this because he was the one who was managing the entire process and would be in a much better position to speak than I would be.
Good afternoon. I'm Anthony Harris. As Dr. Walcott said, Mr. Walcott, Minister, I was in charge of leading the charge for this program. And yes, I absolutely agree with you. In fact, the first step we took was to look carefully with CDRC. That's the Chronic Disease Research Center, the George Allen Chronic Disease Research Center. As you know, they manage the Barbados National Register, which looks at the data for 3 diseases, that being myocardial infarction, stroke, and cancer in Barbados. So they were our data collectors, our data analyzers, and we brought them in right at the beginning to ensure that they were measuring exactly what we wanted. As Mr. Walcott has pointed out, they have, I think, sometime last year, early December, has released some data which showed that there was some improvement, a hiccup in the COVID period, and hopefully it would continue with a downward trend thereafter. But those data trail what we are trying to do. The other thing we did was, to keeping it scientific, was to just look at the workload that the cardiology department was facing, and using this PAHO provided software called WISN, which is, I don't remember what the acronym is at this time, but use that to determine what our staffing levels would be. And quite generously, I think the Cabinet of Barbados agreed to that and passed those numbers, and we have been grateful for it. And it has certainly led to what the Executive Chair announced earlier, that we were able to get the staffing for the cardiac suite, and we continue to work to get the other professional posts in place. Yes, there was an agreement with the urgent care centers because data provided by the CDRC had demonstrated clearly that as much as 30% of Barbadians and visitors were seeking care at the urgent care centers. So I'm quite happy with this because it really demonstrated a private-public cooperation, and we were able to get MOUs, which basically allow them to be able to deliver the care needed for heart attacks in a very timely fashion, because normally what would happen, the persons would go to the urgent care center, they would be diagnosed. The urgent care center is staffed, almost well-staffed. I think certainly a large number of their staff have had emergency medicine training, and they're more than familiar with diagnosing heart attacks. But they would put them, diagnosing and treating, but they would put them in an ambulance and send them to the Queen Elizabeth Hospital. And we were finding that that was adding as much as 2+ hours to their thing. And in the management of a heart attack, we are hoping to get it within as soon as possible. If you can start treatment within an hour, you save myocardial muscle, and you almost have no lingering side effects. If you don't do that, after that time, there is gradual loss of heart muscle. So obviously, in a time-sensitive situation, we want to be able to put it out to the field that people can do. In the developing countries, where an ambulance drive might be long, as much as 45 minutes, they're actually being done by the paramedics. So that brings us to the other thing, working closely with the ambulance service headed by Dr. Bayer. We have been able to get the ambulance personnel trained. We have recognized and urged the ministry to lend a voice for the restart of training of paramedical personnel. And also we have been able to bring, using the specialists at the hospital, ensure that the training of these people in emergency cardiac care was provided. The minister has suggested that they went ahead and did it quite quickly. They would need to be retrained, but I don't see that as a negative, because I think this is a training that is going to have to be continuously provided and redone going forward. And also, I would like us to take some credit for the constant in the areas that we need to increase the number of ambulances. And I now believe that we have a fleet of 9 ambulances with a further ambulance to come to bring that up to 10. We are sneaking very closely to the ideal of 12 ambulances. So anywhere between 10 and 12 means that we should be able to have better response times and stuff from our ambulance personnel. But not only that, the ambulances themselves have been outfitted with sophisticated monitoring equipment that gives the potential for transmission of medical data from the field straight into the accident and emergency and other areas of the Queen Elizabeth Hospital. Long before the person gets there, they can be prepared for and stuff, which should make it very possible, and hopefully, yes, it has happened, where they can know what is coming, get ready for it, and therefore be treated with alacrity. So those are the things. And the other piece...
Yes, Mr. Harris, you will wrap up.
Well, so there have been some successes, and those are the numbers. What is left now is for us to go out there and have the public awareness done quickly. And I will just say that we were guided again by having, getting a consultation from the Carefield School, UWI, Professor Dwayne Devnish, to let us know what exactly were the gaps in people's knowledge of how to recognize themselves or family members having a heart attack. And that has guided us with we have developed a strategic program to be implemented in this budgetary year going forward for increased public awareness and stuff. But I would warn that this is not going to be something that's going to be a 1-month program or 6-month program. What our overseas consultants are telling us is that they have done it, and it takes a long time. So we will
Yes,
be
Mr. Harris,
going for that.
What I'm telling you is that you have exceeded your time. Thank you.
Thank you very much, Mr. Harris, for that wonderful response. And I have too, watching the time, just to say that one other thing that I would like to see added to, because I'm not sure if you've added it, but the proliferation of those defibrillators that are available all across. I specifically asked that it be at Cabinet Office, but you know what? Only now we have Cabinet Office somewhere else. So, and also to the Clerk of Parliament, I'm not sure if you have, but it's something that we should have in these halls, is those emergency defibrillators, because you never know. You never know. And I think that that is something that we can add to be able to have that, and then the public training for that. But I thank you very much. From what I hear, you are on the right track, and I have no doubt that at some point we'll be hearing very good and very positive, measurable results from that cardiac program. Mr. Chairman, I thank you.
Thank you, Honourable Member. Just let me advise honourable members, we want to wrap up this head, so I'm asking, we have 2 more honourable members to speak. I'm asking you to be very brief. You pulled your questions together one time, and the member and his team will answer. Honourable Member for St. Andrew.
Thank you, Mr. Chairman. I will be brief. Coming out of COVID, we would have seen the proliferation of technology, new innovations in a number of different sectors. I know that many other industries had the opportunity to pause, recalibrate, and to strategize, whereas the health sector was forced to double up and increase efforts. However, lessons that were learnt, many would still apply to the health sector as it relates to technology especially. I know that it was alluded to here this evening on one occasion, but how, I'm going to inflate 2 questions into one. How has the QH, the Ministry of Health, embraced technology as it relates to patient care and the proliferation of such things as the member for St. Michael's South alluded to, telemedicine, telehealth? How are we integrating such technologies into the deliverance of health care for our people? And I also want to go in the opposite direction, since I'm conflating these questions. In the past, we would have had community-based community nurses. We would have seen, certainly in other ministries, the benefit of having persons allow the dignity of, in other cases, aging in place, but there's also a concept of healing in place, where persons would rather have health care at home. And in the past, community nurses would have been responsible for going into certain communities, some of which would have been underserved, and treating to those persons who, for whatever reason, do not come to our medical facilities. There are men, and this is a known fact in Barbados, who are literally afraid to step foot in medical facilities, in doctor's office, and even in the hospital, unless they absolutely have to. And in many cases, at that point in time, it's too late for them. Can you share with this honourable chamber any plans as it relates to the revisiting or the expansion of your community care program, or as it relates to your use of technology in the hospital?
Thank you, Minister. I am going to take the last question first because this is easy. I dealt with this at length earlier today. I don't know if you were here. I don't believe you were here. As your colleague asked specifically, and I spoke about how it was obtained in the past and how I felt about it. And we have embarked on training 3 cohorts, I believe, in the first instance to resume the whole process, to give us the human resources we need to do this, because we've certainly moved away from community nursing. It was one of the strengths of Barbados' system back in the 70s, the 80s. As I said earlier today, to repeat myself, that we were second only to Cuba as related to community care. And we certainly need to get there. Take your point with persons who find difficulty in getting to clinics and to health institutions. It is necessary, so it is something that we are working towards, but we have to build the resources to accomplish that. Your next question, I'm going to toss to the QEH. It's an interesting question. Perhaps I will come in at the end of how they have benefited in terms of advances in technology, etc., in the light of COVID. So I'm going to ask, I don't know, perhaps Dr. Williams?
Want me to do it? Okay. Yes.
Shani Williams, Acting Director of Medical Services. You're correct, Honourable Member, about how COVID has taught us a lot. And there are several things that we have used pre-COVID, but more heavily during COVID as it relates to the engagement and commitment to technology. So we do telemedicine, where some clinics are actually run virtually, if not fully, partially. The psychiatrists do teleconsults remotely. Most of our diagnostics are available electronically as well, so we can do computerized order entry, and the radiologist can do remote interpretation of imaging and reporting. We're also working on some of our departments have a limited electronic medical record capabilities, our staff clinic in particular, and the radiotherapy oncology departments. So we're hoping again, as our asked during estimates, for the investment into the technology so that we can be more widespread as it relates to hospital-wide information system. There are some other innovations that we will do. Mr. Harris would have talked about the Bluetooth and teleporting of ECGs and other images from pre-hospital into the emergency department so that we can view your heart rate readings and tracings prior to the arrival of patients. So those are just some simple examples that we're trying to bring together to be one comprehensive package with a health information system and the reliance on technology.
Thank you.
You're going to okay. The executive chair to speak briefly to it.
Sorry, just adding just two more points onto Shani's. We also have now the capability of doing pharmacy online pharmacy delivery that more and more Barbadians are increasingly taking up, which was an innovation of COVID. Or help desk, we're one of the only help desks in the country that's actually manned by physicians and nurses. And as a result of that, we're able to do tele-triage, case management, a lot on the telephone because it is a service that is available to the public of Barbados. And lastly, the new frontier is you're familiar with Barbadians coming to the Queen Elizabeth Hospital just to set up an appointment. We're in the process within the next few months of establishing an online system that people can, just like the US Embassy and other agencies, actually make their appointments and not have to come to the hospital and see that congestion. So you're correct that COVID has provided the opportunity to move the hospital very quickly in areas of technology, and we're working on building out the infrastructure around it to be able to do it efficiently.
Thank you. And just one last...
I'm sorry, there's just one thing that you mentioned in terms of using technology. One of the biggest opportunity is for nursing documentation using a tablet in real-time assessment so that that information can be transferred throughout our facility. Right now they are documenting their findings, their assessments on paper, but the use of a tablet with giving them the opportunity to document electronically is something that we can certainly look at in terms of the timeliness and the relevancy of the assessments that they're doing in the community.
Yes. And my final question, it is one of a parochial nature, but I could not live with myself if I did not ask this question. And it relates to the St. Andrew outpatient clinic. May this year will be 2 years that we have seeing the reopen of that clinic. The people of Belle Plaine and people of St. Andrew are eternally grateful for the reopening of that facility. However, we were promised at the time that the opening days would move from 3 days to more days, but that has been reduced to 2 days, 2 half days. So in essence, it's really just 1 day. So I'm asking if, going forward, if there are any plans to perhaps look at these St. Andrew's outpatient clinic with the view of increasing the number of hours, or at least the number of days that persons can be treated at that particular facility.
Thank you. Honourable Member, I understand your concerns, but at this point in time, and as it relates to the resources, you would appreciate that we take nurses from Eunice Gibson, I believe, polyclinic to cover these 2 days, and then we're having issues of complaints of it affecting clinics at that polyclinic, persons' appointments, etc. So it is a matter we are aware of, and again, we need the additional nurses, and doctors, I believe. So that is the issue right now. And unfortunately, there's no provision has been made in this year's estimates for that. It is something that we want to look at, but certainly not in this year's estimates. Thank you.
Thank you, Minister. Thank you, Mr. Chair.
Thank you, Honourable Member. Honourable Member for St. Michael South.
Thank you so much, Mr. Chair. I will be very brief, I promise. My first question is in relation to HIV and AIDS, because I haven't heard much about it during the course of this conversation, and I do not think that Barbados should keep that off the table. And in a conversation about health, it should really be one of the things we discuss. And I say this because I know during COVID, and I know COVID has consumed a lot of our resources and professionals, but during COVID, it was difficult to get numbers in the ministry for HIV and AIDS. And so I want to pose the question, where are we really in relation to the fight against HIV and AIDS? And we are reshaping in the ministry the HIV Commission to include other behavioral changes that we think are necessary. But I do not want persons who are probably, who have HIV in Barbados or who are potentially exposed to HIV to feel as if Barbados has abandoned that fight. So I want to know where we are with HIV and what are your plans in that regard.
Thank you, Honourable Member. I believe you weren't here this morning when I spoke about this, but I did say that it was affected during 2022. We had breaks in the provision of diagnostic testing and viral load testing and CD4 testing, all wrapped up with the issues of COVID. And I am saying that we recognize that this was indeed a problem, and I want to tell you that within the last 3 to 4 months, the capacity of the Best of Santos lab to do these tests has been restored. I also am going to mention now, since you've expressed your interest, the WHO has recommended the use of a new drug, dolutegravir, and as a preferred first-line and second-line treatment for all populations, including pregnant women and those with childbearing potential. And I'm pleased to report that we have began to make the transition, and 12% of our persons are currently on this preferred first-line drug. Also, we have restarted the pre-exposure prophylaxis, so the use of antiretroviral therapy among persons not infected by HIV to prevent its acquisition. This was initially done at the LRU and Equals Barbados, but we've now extended this to the St. Philip Polyclinic and the Barbados Family Planning. We'll resume our STI clinics, and we plan to go into the community again shortly. I'm going to ask Dr. Anton Best, in the absence of Dr. Babu, who has responsibility for this sub-program, to speak, to respond to the rest of your questions as pertinent to this.
Thank you, Minister. Mr. Chair, Anton Best, Deputy Chief Medical Officer. Thank you very much for the opportunity to just say a few quick words to add to what Minister Walker would have said regarding our efforts in the Ministry of Health and Wellness pertaining to HIV and STI prevention and control. We have a comprehensive program in place. Just last year in April, the Lady Mead Reference Unit would have celebrated 20 years of being open. And this is critical because the public health world and the world of HIV has recognized that HIV treatment is at the center of being able to control this epidemic of HIV that is still occurring globally. But please appreciate that when I say that treatment is at the center of it, that everything can't be about treatment full stop, because you still have to find ways to get the most vulnerable people aware of the fact that these services exist. You still have to find ways to overcome the barriers and the obstacles for persons to access the treatment that is required. And of course, before accessing treatment, persons need to be tested. So yes, Minister would have touched on the testing aspects of it, what the Best of Santos Public Health Lab is doing in terms of the diagnostic tests and the tests to support the management of persons living with HIV. We had some unfortunate setbacks during COVID, but the testing has resumed. I also need to state that frequently we forget to talk about the other sexually transmitted infections. And I'm going to mention that the rates of chlamydia, which remain about 13% in the adult populations, rates of gonorrhea, which remain about 2% of all of those persons being tested are positive. And then the rates of syphilis remain unacceptably high in Barbados. And this is important because it is indicating to us that more people are vulnerable to HIV because of the high prevalence of sexually transmitted infections. And the previous paradigm that we can change behaviors and people are going to wear condoms and people are going to adopt safe behaviors and reduce the incidence of HIV, we have to move away from that paradigm. It is all about testing people, getting people diagnosed as early as possible, and getting them into treatment. So please see sexually transmitted infections in the context of a comprehensive program for HIV and STIs. There's not much more I can mention that the minister hasn't said. He would have talked about the combination prevention approach. So I would have talked about aspects of that in terms of the testing and the importance of getting people into care, and then other treatment and modalities such as the PrEP program, which started in 2018. And PrEP, just to reiterate, is the provision of antiretroviral therapy to HIV-negative persons who are at risk to reduce the likelihood of them acquiring HIV. So we are on the ball in terms of the treatment modalities. What we need to strengthen, however, are the services that we provide, the supportive services that we provide. We have taken a hit since COVID, and these are issues that we have brought to the attention of the Minister of Health and senior officials within the Ministry of Health. We continue to work with the HIV Commission, which as it stands right now remains the coordinating agency of the national HIV response. However, I would argue that the lion's share of what we do comes from the public health approach, and I would have talked about what the public health approach entails. I hope that satisfies your concerns. Thank you, Chair.
Thank you, Dr. Best. I noticed that you mentioned HIV Commission, but you didn't. I believe that we need to have a meeting with the Ministry of People's Empowerment at some time regarding the relationship between the HIV Commission and the HIV program. I know that you didn't mention it, but I'll mention it. Thank you.
Thank you very much, Senior Minister. I trust you could thank me later for giving you the opportunity to elucidate and to allow your team to add further value to your initial contribution. My second question is really in relation to policy, the health policy and research. I know that there was a very active policy or research unit, I'm not so sure what it was properly called, but busy with research and driving the research agenda. I'm just wondering in relation to all of these issues that we've heard today, and there have been several that are facing health, whether in Barbados or globally, in relation to the way things are evolving, even in relation to dealing with COVID. And I don't just mean technology, I mean dealing with a pandemic. What is happening with the policy or the research section of the ministry in relation to being able to give us that kind of empirical, research-based information that would allow us to make, I think, better decisions. Only because I'm thinking of the care gaps that we're talking about, the treatment to patients or of patients, the various social determinants of health, even as they too have evolved. What is the relationship and in what is the role for driving the thinking in the ministry in relation to research and that unit?
Thank you, Honourable Member, and you raised a very important point. A concern of mine when I was last here too, I believe we were working out the percentage of the health budget that should be directed towards research. It is very important, and especially homegrown research is absolutely important. The living lab that I spoke about earlier brings some research, but I see the research that you're speaking about in terms of NCDs, etc. Right now, we have a collaborative relationship, or we pay for services from the Barbados National BNR, the National Registry. But I get the impression that there's a paucity of actual research within the Ministry of Health and Wellness. I understand the circumstances. We have short staff in several areas. Staff are stretched out. Certainly, come during COVID, it would not have been possible. But I take your point that this is the opportunity for us to start doing some in-house research. I'm sure that Dr. Roth would agree that we can do some stuff as it relates to vector control, the insectary, the type of mosquitoes are here, looking at vector-borne diseases. Some simple stuff I believe we can do. So I take your point that I'll ask the CMO, perhaps he will want to bring his experience to this.
So thanks, Minister. Yes, a research agenda is absolutely critical to drive policy. A couple of reflections. Research, if not done well, and if done shoddy, will lead to false information. We have mentioned in this room that we are trying to do NCD survey, which is a telephone-based survey to get some very basic information.
Sorry, Chair, I don't mean to cross you, but I cannot hear you.
I said that our research agenda is tied to a couple of things. This year, we're hoping to do some NCD risk factor research, and that has been budgeted for. It's a low-cost intervention. Minister mentioned the BNR, which is the registry, which gives us information on many chronic diseases, including including hypertension, stroke, cardiovascular disease, and cancers in Barbados. So the point I was making, research is expensive, and frequently, if we're going to do it, we have to collaborate with other agencies. We are willing to do that. But I don't want the chamber to believe that research is extremely expensive, and we in the ministry, we deliver services, we are a regulatory body, so many times we don't have the wherewithal to do in-depth, credible research.
Mr. Chair, I don't think I have to tell anybody that planning without action is futile, but action without planning is fatal. And I'm not convinced that I've heard from the senior minister, which is helpful, but I am not convinced that I've heard what is the real role in terms of the research agenda, the unit. Is there still a unit within the ministry? Has it died? Where are you?
Yes, there's a research unit. It is not staffed the way we want it staffed. We have some vacancies which we have to fill, and right now we're looking at doing a restructuring in that regard. And yes, you need research to drive policy. I totally agree with you, Honourable Minister. What the CMO neglected to say is that in the next financial year, we are going to be doing an NCD risk factor survey. And it's over a 2-year period, and it's not a quick and dirty, as he might have alluded to, but it's actually a very comprehensive research agenda that we're going to be undertaking on. We're getting assistance from PAHO, and our health planning unit will work with PAHO, but we're also going to be working with the George Allen Chronic Research Center as well. Over a 2-year period, the project will cost about $450,000 CMO. And so therefore we have to tackle it over a 2-year period. We're also going to be working on our national nutrition policy, which is being coordinated not only by Ms. Dr. Phillips, who's the SMOH for NCDs, but along with the focal point will also be in our planning unit. So the very few people that we have that can count on one hand, which is responsible for a very multifaceted healthcare sector, are the ones who are working to enable us to have the research that we need for policy, but we always work in a collaborative way with our healthcare partners, especially PAHO and the University of the West Indies.
Thank you very much.
Thank you, Honourable Member. Honourable Minister, you can now wrap up.
Thank you, Mr. Chair, and to thank you all the honourable members of this chamber for their questions and their suggestions. We have taken note. We understand your concerns. We have shared with you the challenges which we face and the plans that we have going forward. I want to say that the Ministry of Health and Wellness will certainly continue to move the health agenda forward as we work towards the goal of universal health coverage. And I simply want to again thank the staff of the Ministry of Health and Wellness and of the Queen Elizabeth Hospital for the good work that they have provided and continue to provide. Thank you, Mr. Chairman.
And with that, Mr. Chair, I beg to move that Head 86 stand part.
Made a second.
The question is that Head 86 stand part. All honourable members in favour, say aye. Honourable members against, say no. Methinks the ayes have it. Honourable Leader of Government Business.
Thank you, Mr. Chairman. I beg to move that you do now report progress to His Honour the Speaker and beg leave to sit again.
The question is that I do now report progress to His Honour the Speaker and ask for leave to sit again. All honourable members in favour, say aye. All members against, we say no. Methinks the ayes have it.
The chairman has reported progress and requests leave to sit again. Honourable Leader of Government Business.
Thank you, Mr. Speaker. I beg to move the suspension of the sitting until Friday, 3rd of March at 10 a.m.
The question is that this honourable chairman be suspended until Friday, the 3rd day of March 2023 at 10 a.m. in the forenoon. All those honourable members in favour, please say aye. Those against, please say no. Meeting the ayes have it. This honourable chamber stands suspended until Friday, 3rd day of March 2023 at 10 a.m. in the forenoon.